the example that you just gave, trying to differentiate between, and by the way, when I was in physical therapy school, I enjoyed my program and there was a lot of great things, but we still learned manual muscle testing in that way. This is 5 years ago still, teasing out each muscle as if we could.
Yeah.
And then manual muscle testing and also other things like quote unquote flexibility testing for each individual muscle, as if the body works that way in these
it's crazy, isn't it?
Compartmentalized things. But the example that you just gave, maybe it's a supraspinatus sprain, or no, I think it's teres minor. Does it, in regards to examination, how much of that matters? Can we simplify it by simply saying, you know what, it's your shoulder hurts when you do this. Let's see what your triggers are, or do these individual tissues or local areas or diagnoses sometimes matter from a physio standpoint?
I think sometimes is probably the word I'll use here. So I don't exclude structural pathology or diagnoses completely, but I am aware that our ability to label something in the shoulder that hurts nowadays is notoriously difficult. And so I'm always suspicious of other diagnoses as well. But I do know that the evidence tells us there are clusters of tests that can give us a higher sort of probability and certainty that there may be a pathology producing some provocation on certain movements on certain tests. So I will, I will hedge my bets and say there is a probability here that it could be this particular pathology that's causing your pain. But does it change my management? Absolutely not. That's the biggest thing, is that I find, a lot of the time I can say I've got a hunch that it's X or Y, but I'm going to treat it exactly the same. I don't change my management very rarely just because of a structural pathology. It tends to be other things that guides my treatment program, and that tends to be the individual, the direction that they've got pain and problems in, and their attitude towards it. And I don't want to give too much away from my webinar, but I very much tend to, just guide my treatment based on those key factors. The structural pathology is there in the background, but it's very low down on the list of why I'm going to do or not do something.
Well, I think that's an important point, because our thought process is we want to be these expert, we're talking just physio land here, we want to be these expert diagnosticians, and in my mind, by definition, a diagnosis should guide your treatment. So if we're giving you a specific diagnosis, your intervention should be different if the diagnosis was different. And so if our special tests guide us towards a quote unquote rotator cuff pathology or quote unquote labral pathology, well, do we have labral exercises, or do we have a labral management plan versus our rotator cuff management plan? I think that it is chopped up to seem that way, but ultimately, do we? It's like what you said. What's a rotator cuff exercise? Every shoulder exercise that you ever do. So,
absolutely.
When you talk about your clustering your special tests, because I agree with you, we got some data that shows that we can put them together, and the validity and reliability is a little bit, or the validity is a little bit better. What information does that give you? Is it just something that you put in your back pocket? Like, if down the line we're not getting the results that we want, now I can have a conversation with a referral source and that type of thing, or does it matter to the patient also?
Yeah, I think if we use the example of, say, an acromioclavicular joint, let's say we got a grumbly acromioclavicular joint that's giving somebody some pain when they're pressing, doing something, and we've done our cluster test and said, yeah, there's a high probability here that the ACJ seems to be symptomatic. Could be other things as well. We haven't excluded everything else, but it seems like this cluster of tests we've done is quite provocative for this individual. It sounds or it feels like it's an ACJ. So then we go through our rehabilitation and we do as best as we can do. We load them up. We try and, but maybe we unload them first. We let the shit calm down and then we build it back up again. We go through the rehabilitation, we give it a sufficient period of time, and it's still grumbling away and it's still not happy. Then that sort of diagnosis now then sort of comes to the forefront, and I start to say, okay, maybe there's other options here, because believe it or not, physiotherapy don't cure everybody. So I will then say, okay, well, this is, we've given it a good shot. It still doesn't seem like it's doing what I'd expect it to do at this stage. I would probably say there are other options to the patient that they might want to consider and suggest. And again, believe it or not, sometimes I am a fan of a steroid shot. Again, maybe that just helps calm shit down for a period of time. I know we've got to be sensible about it and rational about it, but again, I see a lot of kickback with steroid injections and people going over the top saying they're the worst thing since sliced bread. I'm like, no, they're not. They can be useful adjuncts, for some treatment for some patients. Just be sensible about it. And that goes with surgery as well. And again, if there is still a grumbly ACJ in there, and the scans are showing it's lighting up like a Christmas tree, and then a small little, distal excision, that can work wonders. I've had patients come back absolutely fantastically after that. So again, I think we demonize our orthopedic colleagues a lot, especially on social media, and think physio is the all end and be all. And it needs to be given a good shot. It needs to be used as a first line treatment. I agree with that. We need to be promoting that more. But it doesn't get everybody better, and that's when other interventions are useful for us to be thinking about. And so that's where I think structural pathology diagnoses can be helpful.
So you kind of bank. I love that, by the way. And I actually just yesterday had a conversation with a patient about the possibility of getting an injection to kind of, like you said, and to quote Greg Lehman, calm shit down, build shit back up. And actually, like after the conversation, I felt a little dirty. Like, no, like, you know what I mean? Like the internet's going to blast me if they knew that I just had this conversation with somebody, but I completely agree with you. So, and just to summarize what I think you're saying is like the structural pathology, you at least determine that you just get the big picture and you're banking that information, and then you pull it out if you need to. Do you also bring it up like to the patient? Let's say it's AC, you think maybe a probability of AC joint pathology, you have the conversation with the patient, but then you make sure that you say it doesn't actually matter as far as what we're going to do, but if we had to pin it down to a specific area, I think this is what it is. Or do you not even tell the patient that in particular? Does it depend?
It depends. I think, if the patient asks for a diagnosis, I think my first question when a patient says, what do you think's going on here? I say, well, why do you need to know? And if a patient tells me that, I'm interested, what's your thoughts of what's going on here? And then again, I say, well, why do you still want to know? Well, I went and saw this other guy down the road, and he told me that it was this thing that was going on here. I said, so you've already got another diagnosis from somebody else. So then it starts having to be a little bit careful, because again, I know sometimes giving other patients different diagnoses starts to get quite confusing for them. And that's when they can start mistrusting me or mistrusting somebody else and end up going down a very sort of dark hole, and they go and get a third opinion and then a fourth opinion. So I will always say, to a patient, if you want a diagnosis, why do you want the diagnosis? I try to explain to them that, my management doesn't need it. I've ruled out anything serious or sinister. But if you really want to know, I've got a suspicion that it is this. And then, try to keep the education, realistic, simplistic, and rational and hopeful as well.
What do you think about this? Because I've had this exact conversation with people, and the rebuttal on the other side is it's unethical, and we're going down this road right now. It's unethical. We talk about differential diagnosis. It's unethical to withhold the differential diagnosis from the patient. And the conversation, so that was my face. The conversation was actually, that I remember specifically, was about it wasn't about the shoulder, it was about the lumbar spine, and it was about disc pathology. And it was a patient, the example was a patient who's not presenting with radicular symptoms, no red flag symptoms whatsoever, and it's just localized pain, flexion sensitive, but just localized. My thing was like, what my diagnosis is? Back pain. Pain with, but the pushback was it's unethical to not tell them that it could potentially be spinal pathology or something like that, and we may need to do down the road, do an MRI, something like that. In real doctor land, probably offend some of my colleagues, real physician land, it would be like more sinister medical diagnoses that you would need to tease out like that. That's kind of what they're referring to. Do you see us in physio land when we're talking about the shoulder, or the knee, being on that level, needing to tease out these diagnoses?
No, I think we need to be, let's say, looking for the serious, sinister stuff. That's the main thing. So if there was a radiculopathy, there's something in there with neural compromise, then clearly you're going to have to explain that and give that diagnosis. And likewise, if there are any red flags as well, you're going to have to clearly give that diagnosis that there could be something else going on here. But for everything else where there isn't that clear, sinister, serious pathology, and it's this mushy mess of symptoms and possible suspects, then I'm with you. I will call this a painful area, a hot spot, an anatomical problem, with regards to the back pain or shoulder pain or knee pain. Yeah, but I wouldn't give it a label as anything that's structural. No.
Do you think part of the issue is the diagnoses that we have at our disposal themselves that are just they're basically just diagnoses of exclusion, like subacromial impingement syndrome or impingement syndrome, or I mean, even tendinopathy is diagnosed without imaging confirmation, and it's just based on the history of the symptoms. So do you think that's an issue? Is the fact that our diagnoses are nebulous?
Absolutely. I think it's a big issue. And again, I think it's physiotherapists loving to rush down and give things diagnoses and labels. Physios like to categorize and box things, working on algorithms, procedures and formulas. It's just their training, it's their background, it's their mindset. Give them that little bit of ambiguity and that little bit of uncertainty. Their brains just go, they're like rabbits stuck in a headlight. They're like, what do I do now? How do I proceed? I haven't found A, so what I can't do B. Surely. I'm like, no, you can. you can still treat people. You can still do what you've always been doing. You just got to not always have a label. You don't always need to put a diagnosis onto things. But yeah, the classic one I see, rotator cuff tendinopathy as well. I hear that so much. Oh, you got the diagnosed rotator cuff tendinopathy. Well, how do you know? Oh, they've got pain on external rotation. That doesn't mean it's rotator cuff tendinopathy. Well, yeah, even if you have a scan and it shows rotator cuff tendinopathy, we know you can see tendinopathy changes in the rotator cuff on asymptomatic individuals. So you still don't know. It's the diagnosis. I mean, it is frustrating and it is annoying, I think, when physios hear me talk and I explain things like this. And I always say to them, look, if it gives you any consolation, I am a big hot mess of uncertainty. I am this big mixture of contradiction. I am on a daily basis going, well, it could be this, could be that. Inside, I'm in turmoil. But on the outside, I don't show it. I am with patients. I am confidently uncertain. I think that's the other thing with uncertainty. When you're trying to give a diagnosis to somebody that you're not 100% certain about, you have to give it confidently, because patients don't respond to somebody that's going, could be that. They're not going to buy into you. They're not going to trust you. So I think, again, it's how you do it. And that's the skill of a physiotherapist as well, being able to know the evidence base well enough and to be confident in it well enough to be able to explain this to a patient confidently, but still uncertainly.
And let's see if you agree with this. Sometimes I actually think that simplifying things or pulling back from specific labels or specific tissues is actually a breath of fresh air for the patient themselves. So I'll try to say, for the shoulder specifically, I say, I even have a little anatomy app that cuts things and does all this. It's see all these ligaments around your shoulder? Could be any of that. And then I start adding muscles, and it's there's stuff, so it could be a combination. Let's just say all of these tissues are pissed off. We don't know. It doesn't matter. But this is the area, and they say, okay, I mean that makes sense. It doesn't really matter if when they start to see that it's just big picture, I think that helps things along as well. They're actually they're actually refreshed by that.
Absolutely. And again, it goes with those patients that have had multiple different diagnoses and they're confused now and they're a little bit uncertain. They don't know how to proceed. They're like, well, it could be my slap because that guy told me it was a slap lesion. And now this other guy's told me it's a rotator cuff problem. And I've been also told my bursa needs an injection as well. And then they come to see me and I say, well, technically all of them could be right. Or they all could be wrong, but it doesn't matter. This is my plan. I've excluded anything serious and sinister. What we're going to do now is give it a shot at doing these things, and we'll see how it goes. And I've got a high probability and a high suspicion that you won't need any further interventions, just giving it some time and some loading, and we'll see how it goes. And there's evidence to prove that patients respond to that as well. I'm trying to remember the name of the paper because I use it on my course. it's got a German sounding name, Schellinghout, 2008. We should abandon structural diagnosis for subacromial shoulder pain. And it's an awesome read. And it says basically this, that patients are in terminological chaos. I love that phrase. It always sticks in my mind, that patients, when they get multiple diagnoses, end up in terminological chaos. And I think you're right. It's reassuring when somebody like you and me says around, look, it could be this, it could be that. They've got all these other things in there. Doesn't matter. Nothing there serious for us to worry about. This is what we're going to do. Here's the plan. That's what the patient wants. They want a plan. They want to know what to do. They want the action. They just don't want the diagnosis. Again, let's give them that. Let's give them the plan. Let's see how it goes.